we started introducing this after actually I listened to Louise at the BLS conference, and I'm sure you've all been to conference and you get really inspired and you think, oh, I'm going to do that, I'm going to do that, it's going to make such a difference. And then when you get back into practice, you sort of get back into the daily grind and nothing ever really changes. But Louise obviously really inspired me because I felt this was actually a really the way forward that we needed to go with our breast cancer patients. So thank you, Louise, for supporting us this far.
And I didn't know Ali until today, and she told me that she heard it in 2008, so that was really good.
So I actually have been in lymphedema since 2002, and I fell into it quite by accident. Know very, very little. Went up and did the course in Glasgow, which was phenomenal. Learned a huge amount. Had about 200 patients on my caseload then, mainly cancer related because we're a hospice service. But we had a few non-cancer patients even then that the hospice supported. We've now got 1,400 patients, so we have grown hugely. Fortunately, it's not just me anymore, we've got about 4 full-time equivalents. We're now fully commissioned by the CCG. We had a change in about 2013 where our chief executive no longer wanted to support the lymphedema. Oh, what am I doing? Sorry. No longer wanted to support the lymphedema service. So that was a bit of a scary time. We didn't know if the CCG or PCT as it was then was going to take us over, but they actually did. And we've got really brilliant commissioners. We're very, very lucky in Somerset. So we've grown to where we are now. So today I just really want to talk a little bit, and I try not to be too long because I know you've got to get home tonight. Why we actually looked at why we needed to change our practice back in 2009. The challenges of collaborative working, because we're a hospice, we had to work with our local hospital. So working across 2 different organisations had huge challenges, which I think Louise mentioned. It's not just your service, you've got to get other people on board as well. How we develop the pathway and the policies, the protocols, the guidelines that all had to be in place before we could even really start this. Our patient education programme, which was crucial, and then the audit and the evaluation that we've done too now, just to see that we're actually making a difference to patients and it's what they want, as well as being cost effective for us and for our commissioners. A dodgy time last year when we had a big change in our breast cancer surgeons. We got 2 very new dynamic surgeons whose patients never get lymphedema, and they actually questioned whether we needed to be doing this. Well, one of them did, so we had a fight on our hands then. And then really what we found from using the LDEX and what we'd like to do in the future. So this is looking back in 2009. We had a new breast care nurse who had joined the service over at our local hospital, and she was very, very keen. She attended one of our awareness days, which is a general lymphedema awareness day. She was really, really keen to improve the pathway for breast cancer patients. So I had an ally, and that was probably the starting point and the most important part of it. If I hadn't had Karen on board with me, I think this would have been a much harder battle, which we possibly may not have won, because she was so enthusiastic about it. We were getting an awful lot of late referrals to the lymphedema service. Now this lady had a huge arm when she was referred to us. That didn't happen overnight. And there were many like her, really. There was no clear referral pathway. The hospital actually had a very small lymphedema service run by a physiotherapist, and she had probably about 4 hours a week, I think, doing lymphedema. She'd been doing it for a long time. She was very near retirement. I think she was overwhelmed with it all. And she got a lot of the breast cancer referrals, and that was mainly because the existing breast cancer nurses they didn't like referring people to the hospice. Obviously, when you've just been diagnosed with cancer, you possibly don't want to go straight to a hospice. But she was sort of colluding with this myth that if they came to the hospice, that would be it. You don't want to go there, that's where people go to die, and this was one of our breast cancer nurses. So we didn't get all the referrals. The ones we did, we had good outcomes with, as long as they weren't too late referrals, but we got a lot of patients referred to us later on who'd actually not been terribly well managed. There were no pre-op measurements. At that time, it probably wasn't. Now we all think we need pre-op measurements, and that wasn't probably the case there until I heard Louise. There was a lack of patient education in breast care, so they were getting very little information about lymphedema, and that also was because they didn't want to scare the patients, but actually the patients were already scared about lymphedema. That was one of their main concerns. So healthcare professional education as well. There's a turnaround of junior doctors who would be running the clinics. They didn't know a lot about lymphedema. A lot of the GPs didn't know a lot about lymphedema. Nurses on the wards didn't know a lot about lymphedema. We didn't have a designated breast cancer surgical ward. They would go anywhere in the hospital where there was a bed, and that was another problem that we found as well. I say misbelief about the hospice, which was, came very much from the breast cancer nurses, which was quite a concern for us. And we were looking then at research on improved outcomes, and we knew that we had to get these patients early. So challenges of collaborative working. We were working with a very established breast cancer team over at the hospital, with one nurse who was really on board with us, and 3 who weren't. The surgeons at that time tended not to get terribly involved. This was sort of nurse stuff. Let's not worry too much about them. They weren't, they were okay. Oh, I've done it okay. Thank you. So I'm figuring out, take it away, put it down. It's the best thing to do. So there was a lot of resistance to change. Our lead, and she didn't get on terribly well with her team lead. And I think this made additional problems as well, really, because she did tend to get her back up a little. I think when you're introducing change, you have to get people on board. You have to work slowly. You have to convince them. She did go a little bit as a bull in a china shop. So there was a bit of work to do there. Perception of increasing the fear of lymphedema, and that was a big one. Everybody said if we do this test, they're going to panic. How are we going to do the test and not panic the patients? We really don't want to do it because they're already scared enough as it is. So we actually developed a very small questionnaire for our existing breast cancer patients that we were seeing at the hospice who had lymphedema. And I know it wasn't ideal because they already had lymphedema, but we said to them, if you'd had the chance of having this test, after your surgery, would you have had it? Do you think this would have increased your fear? And not one of them said yes, because it was already in their minds that that was the worst thing that could happen to them, that they were going to get a massive harm. And when we were at risk last year, we actually asked some of the patients as well who had not developed lymphedema, and they all said they wouldn't have changed anything. They felt it was brilliant. It was reassurance for them. They felt that they were being monitored regularly, and I think this is one of the very important things. We are actually seeing these patients every 3 months, so we are monitoring them regularly instead of them being seen once in breast care and not being seen for another year. If they develop a problem, they don't know where to go. They go to their GP and they might say, oh, well, you've had lymph nodes removed, you might get lymphedema. It was hit and miss whether they would get referred. So I think that's one of the big bonuses. We're actually following them up on a regular basis. Who pays? We put a business case in for the LDEX to our commissioners and they immediately approved it. They were supportive of it. But the hospital had to buy one as well. So that was another challenge. Now the breast cancer service have plenty of money in our hospital. It's one of the most well-off services in the hospital because a lot of patients and people give to breast cancer. So they had the money, but it took a while to persuade them to buy the machine. They did eventually, and then they didn't use it for 9 months, which meant we couldn't use it for 9 months either. So that was frustrating. Governance. So we've got to get policies, we've got to get operational guidelines, we've got to get competencies done across both sites. Another challenge for us at the hospice, it probably took a month. At the hospital it took 6 months. So even changing a leaflet, I'm sure you all know if you work in hospitals, it's not easy. So we had a problem there as well. So we looked at the evidence, we presented the evidence, we eventually got approval. It's doing it again.
I don't know what's happening.
This one. It's changing to
From the current, from the
Yeah, but we don't really want to do it on.
No, but I'll put it.
yeah, it'll take a few time.
I think that helps.
So we actually wanted to see who we were going to have referred to our service. They just started doing sentinel lymph node biopsy then, and we wanted really just to have our high-risk patients referred to ourselves. So we looked at any patient who'd had sentinel node biopsy and had gone on to auxiliary clearance, or if they'd had auxiliary radiotherapy, or if they'd had 12 or more lymph nodes removed without sentinel node biopsy. We've since changed that to 6 because we felt that 12 was far too high a number and we were getting patients referred with established edema who'd had sort of 6 to 8 lymph nodes removed, so we reduced that. The next challenge was who was going to do the preoperative measurements. To begin with, the hospital wanted us to go over and do them. That would have been a logistical nightmare. So we felt between us, with breast care as well, that the pre-op assessment clinic would be the best place to do it because they were already there, patients were there. They had access to a couch, mainly. That was another problem. Occasionally they didn't have a couch. Obviously they needed them because the patient needed to lie flat. And who was going to do it? So the pre-op assessment clinics were mainly run by nurse practitioners, so we trained them as well. And we also trained a healthcare assistant who was dedicated to the breast cancer clinic to do them as well. The ones that got missed was when the assessment clinic was carried out by junior doctors, because we obviously couldn't train all the junior doctors, so we did have a bit of a blip, and we did get a few patients missed there. The next problem was where they were going to document the result in the hospital, and that was a big problem. It may not sound, but it was, and we're still having a problem with that. It went in the notes, but then nobody could find it. We had many, many referrals where the patient said they had had the LDEX done, but there were no results. So that was extremely frustrating. They then had a card index system where they used to put it on and then put it in a little box. That didn't seem to work terribly well. It's still not perfect. They are putting it in the notes, and I think it seems to be found more easily now. We don't often get them lost now, so I think they've improved. But that was really frustrating because that, it's made the whole follow-up a bit of a nonsense, really. So that was frustrating for us. We wanted to develop referral forms. So to start with, we did flowcharts for patients who needed to be referred. And we also did a flowchart for recognising edema because we were still getting patients presenting with edema that hadn't been recognised. They were too complex and they just didn't work. There was too much turnover of staff, and we learned very soon on that they could make a head or tail of it really. It was far too complicated. So we then just had 2 different referral forms, one for our at-risk patients for the prophylactic group and one for patients with edema. And we did a lot of staff education so that they would recognise edema, and that is still going now. They're different coloured forms, they've got different wording on them, and they are very successful and they're simple. So the basic information we want is the surgery the patients had, the number of lymph nodes, grade of breast cancer, the LDEX pre-op result, whether they've had chemo or are having chemo, radiotherapy and treatments, and the patient has actually consented to be referred to the hospice for follow-up as well. Also important, because we did have 1 or 2 who suddenly got a letter from us from the hospice and hadn't been informed, which threw them into complete panic, which is what we desperately wanted to avoid. So a lot of staff training over at the hospital went into that. Time consuming but well worth it. We went to the oncology centre as well where they were having their chemo, and to the radiologists, so we were getting the whole team really. We developed a policy which was approved by our commissioners and eventually by the hospital as well. And we developed a strict protocol for the patient pathway. So they all had their pre-op LDEX done. If they then went on to auxiliary clearance, they were referred to us. We then developed an education programme which they attended. They would then have their repeat LDEX, which would then be followed up every 3 months for the next 3 years initially. So that's how we worked it to start with. We developed guidelines for the use of the LDEX, competencies for our staff, and we also had to look at our skill mix. By this time, our caseload was probably about 1,200 patients, and there were, I think, 2.5 full-time equivalents of us. So it was a challenge that we were actually going to fit this in. At the time also, we had a rotational post from the inpatient unit of a healthcare assistant, 2 healthcare assistants, and they would rotate a month with us and a month on the inpatient unit. And we decided that we would train these girls up, who were very competent, they were level 3, to actually carry out the follow-up LDEX assessment. So they were trained to do that. We've now got a full-time permanent member of staff. They don't rotate anymore, but it was a really good start for them. And they're always in clinic. When we're in clinic, if they've got any problems, they always come to us. You know, if they've got any queries, but they're highly skilled. So that took a while, more staff training. We decided to do a group education programme because of the amount of referrals that we were getting from breast care. We were probably getting 10 to 15 referrals a month, I would say. So to see them individually would have been taken a long time. We also felt that groups would be beneficial for the patients, and they certainly have been. They support each other, they generate a lot of discussion, and we can see a lot of patients all at once. We always give them the opportunity to be seen individually if they have a concern. At the same time, they have their first LDEX reading, so they're getting as much done in that time as possible. We've only had one patient, I think, who refused to attend a group session, and the groups went for her. And that's fine. We got it in our letter that if there's a reason they don't want to attend a group session, we will see them individually, or if they've got learning disabilities or any other problems we feel it's not appropriate, then we will see them individually as well. We evaluated the education programme for 2 years, and we got pretty much 100% positive evaluation from it. We talked to them about all the risk factors. We talked to them about exercise, weight management, what to look for, to, if in between their 3 monthly appointments, if they have got concerns, if they're developing symptoms, that they can always come and see us earlier. So it's very much a reassurance. We also found that it actually was quite support for the patients as well, which maybe they weren't getting at the hospital, which they found really, really useful as well, which was another reason we wanted to do it, but the group certainly worked very well. We revised all our patient information leaflets, so they were the same at the hospital and with ourselves as well. So there was consistency with advice between the 2 sites. We introduced an exercise group. One of our therapists did the Lebed training. She since calls it movement to music, and we've got someone else who does tripudio. So we have a weekly drop-in movement to music class, and we've just started a Tai Chi class as well. And it is mainly breast cancer patients go, although it's open to everybody, but they are the dynamic ones who really want to get up there and do it. We were also lucky enough to start a swimming group as well. And we first started this in our local swimming pool on the proviso that it would be a private session because our patients have huge body image issues, which was fine. It was a private session, but the changing rooms were far from private, and we had children running in and out, and I'm afraid our numbers dwindled to about 2, I think, in the end. But fortunately for us, one of our clinical director's husband worked at one of the private schools in Taunton, and they get brownie points for helping charities. So they offered us their swimming pool. at a very reduced rate. And we have a weekly swimming class during term time and a little beyond term time. For a group of patients, we now get about 20 going every week, and it's really, really popular. We have a lifeguard that is provided by the school. Our support group funds an aerobics teacher once a fortnight, so they can actually do specific exercises, or they do their own thing and they just swim. Some of them, like the lady there in her little life jacket, she walks in the water. She's 86 and has huge health problems, and she never ever misses it. She absolutely loves it. We got a grant for a staircase to go down into the water so they don't have to do the ladder. And it's just been brilliant. We love it. One of our healthcare assistants goes pretty much every week, so if anyone needs help getting in and out or dressing garments, she's on board to do that. So, I mean, that's something we're really enthusiastic about. The insurance was a bit of a nightmare, but we got that sorted in the end. So nobody complains. It's been really good. So in 2013, which is when our chief executive decided to pull out all funding from the lymphedema service, we had to do a very robust business case for the CCG, or PCT as it was then. One of the things they wanted to look at was our at-risk patients and the prophylactic work we were doing. But this time we were actually following up for 3 years, and they wanted evidence that that was appropriate. They were not thinking of stopping us, but they, fair enough, they wanted to find out that we were being cost effective and we were doing the best we could. So our audit really was to look at the time to development of subclinical edema using the LDEX. And we found that most people developed it in the first 2 years, and the third year it dropped off dramatically, and that's when we decided that we would actually reduce it to 2 years follow-up. We would like to do it for longer. The patients would certainly like it for longer. They get very, panicky. We're going to stop, we're going to stop. But they're all well educated, they know what to look for, and they know that we're always there if they've got concerns. So we had to have a cut-off point, and that's what we decided. It dropped so dramatically after the 2 years that we felt that we were justified in doing that. Another couple of things that it threw up we weren't really looking at was the importance of patient concordance, that if they didn't wear their sleeves when they got their subclinical edema, very often it would continue to climb. And then they'd come back and say, your sleeve, please. And the importance of early referral, these big arms that we used to get, so hard to manage, not getting good results with. And we also found that some of the patients actually had presented, we used to see them 12 weeks post-surgery, and I'm not quite sure how that came about. I can't really remember. I think that was I don't know how we came to that. But we felt that was too late looking at this audit. We wanted to see them 6 weeks post-surgery, so we changed that as well. So we now see most of our patients 6 weeks post-surgery. It doesn't always work. And started chemo. I think this was a problem. They usually start their chemo around that time. If you're waiting 12 weeks, they're established in chemo. Sometimes they're not well enough to come, so you've missed the boat with them. If you say 6 weeks, you're just about getting them at the right time. And they got quite angry if they got left. If they felt they'd slipped through the net and they got to us late, they were pretty upset about it. So I've just done another audit, really, because of this, which has made me do it, which is good. And we looked at 77 patients who'd undergone LDEX between 2013 and 2014. And I chose those years because I wanted them to have completed their 2-year follow-up, or more or less, so 1 or 2 that we've got the last 1 or 2. So we were monitoring them 3 monthly for 2 years. The number of nodes removed were between 6 and 21. That can't be right, because the maximum positive was between 23 and 24 nodes, so that's obviously not right. But they'd all had more than 6 lymph nodes removed. So, looking at the patients, this group of patients, 56 of them stayed within normal range, which I would think, what's the value on that one gone? It hasn't come out in the presentation, but I have it. Work it out. Anyone good at maths quickly? It's about 36, 37%, I think, which is probably and they were identified as having subclinical edema, which is probably more or less what we would what we would think really with axillary clearance. These were the high-risk patients. 8 discontinued monitoring. I think one had a pacemaker, which is a contraindication. There were a couple of DNAs, and I think there were a couple of METs as well, metastatic disease, where it actually wasn't appropriate to keep monitoring them. So time of development of edema, still 11% had a raised LDEX on referral, either subclinical or actually a visible clinical edema. So we still have those few. I don't know why that's not in the presentation, sorry. It's here. I will find it. If I can read it. And it's tiny, tiny, tiny. 63. 63. 60. Had a raised LDEX between 1 and 12 months, and then 26% between 13 and 24 months, which is about what we would have expected. That's strange. So these are the patients who'd actually had a subclinical edema. So these are the ones that had the subclinical edema. So that was 37%? Yeah, 37% of patients return to normal and no longer need compression. There are a few that choose to wear it for exercise because they've had a subclinical edema. They feel safer doing that. We always put them in a class 2 compression sleeve, put them in a C2G sleeve, but we also give them a gauntlet to take home just in case of hand swelling. And why we started doing that is that we run over 2 sites and we work with 2 different hospitals, and the Yeovil Hospital doesn't use the LDEX at the moment. They put everybody post-surgery in a compression sleeve, and the breast care nurses manage mild edemas themselves. But we have found that we've actually had quite an influx of patients with hand swelling referred to us because they've been put into a compression sleeve and not followed up. And then they've developed hand swelling.
So they put in a sleeve and then no follow-up?
And not followed up,
Okay.
yes. Yeah. And then they develop hand swelling. So we always, even though we're following them up quite regularly, we always give them a gauntlet and say, if you develop hand swelling, you either remove the sleeve, wear the gauntlet, let us know immediately. So the small 3%, their edema is now stable at about 25%. One patient actually didn't want to wear hosiery, and she stabilised at that, and she doesn't wear hosiery. She still doesn't wear hosiery. We will see, we monitor her, but she is stable at the moment. And then the others have got a degree of edema. They don't all wear sleeves all the time. I think 75% of them have less than 10% swelling, so it's very minimal. They either choose to wear their sleeve as and when, or some of them wear it religiously, depending on the patient. No one has any edema more than 22% at all. So, we feel that's a good outcome compared to what we used to have. We haven't done intensive treatment on any of these patients at all. Because most of them with an edema of, say, less than 20% don't want intensive treatment. Then I had a quick look at what happened before we actually started using the LDEX, and I know things were a little different then. We were getting later referrals, but I just wanted to see, what happened to these patients when we got them with well-established edema. So I looked at 51 that I could dig out, and excluded 5 who developed metastases and axillary metastases. I wanted to look at the excess volume on referral, and then what happened to it once they were established in treatment and how hard they were to treat. So, again, the leg's missing. So, 10%, up to 10%, 27% had less than 10% edema, which was 27%. Quite a significant, it's just over 50% had more than 21% edema, so going into the moderate range really, into the severe. So those were when we were actually seeing these patients. So a significant number already had quite severe established edema. And you look at 10% had more than 40%. Now where were they? They were not picked up. They hadn't been picked up. They were all being regularly reviewed in breast care, but they'd not been picked up or they'd not been referred, which was a huge concern. And looking at them as well, we found that the more severe edemas, we were not getting good results. Anyone with an edema between 21 and 30%, we never got it below 20%. Even with intensive treatment, it began to get fatty, and it would change, and then it became much more difficult to treat. And they got a lot of problems with movement, working, depression. It affected them hugely. So last year we had the old XCA LDEX machine, which became obsolete, and we needed to change it. There was concern both at Breast Care and myself that if it suddenly went wrong, we would be out without a service for lengths of time. So we needed to think about it. It didn't go wrong, but we thought it was going to eventually, and we wanted to upgrade it. Cost implications, we were lucky enough at the hospice that we got a capital grant from the CCG just at about that time, which would cover the cost of two new machines. But we had to get Breast Care to come and cough up as well for their machine. We were going to fund that one as well. So I had some discussions with one of the surgeons, all seemed to be plain sailing. The Breast Care nurse says, yeah, that will be fine. And then I was summoned to a meeting just to finalise it with our lead surgeon, and I thought, it's fine, he's just going to sign it off. 20 minutes before I was due to go to the meeting, I got a call from the Breast Care nurse saying, just want to warn you, Mr. Gill wants to stop doing the measurements, you're going to be in for a fight. Thanks for the notice. I've now got to get all this information in my head, and it was probably the worst 40 minutes of my life. He gave me a complete and utter grueling. He wanted to stop it. He felt that it was unnecessary, that the patients would not develop edema anyway, because his surgery was so good. Why couldn't we put everyone in the sleeve like they did in Yeovil? Would that be cheaper? Luckily, the other consultant there who'd been so supportive did not say a word to support me. But we had one of the staff grades there, a woman, and she was very much on my side about body image. You just had your surgery. Do you want to wear a sleeve unnecessarily? This takes away the guesswork for us. If we get patients coming in with heaviness, we used to put them in a sleeve regardless. We've now got something where we can actually say, you're fine. It's probably the ache, you've done a bit too much, you're fine. So, we used that one a lot, and after 40 minutes he just said, okay then. So it was touch and go. So we were saved. As I say, there are different practices in Somerset. We want to get Yeovil on board with this as well. Whether we will. We will. So we got there in the end. So what we found, and what we're still finding, is that early referral and identification improves outcome. We're following these ladies up regularly. They are reassured, they love it. They don't want to stop it. But unfortunately, because of the cost, we have to draw a line with them. But if they come back in the future, we've got a baseline, we've got somewhere to go with them. They're very reassured. We've removed the guesswork. We're reducing the delay in referral. We've got the Breast Care on board with us, and we're working really, really as a cohesive team, which for the patients is brilliant because we haven't got that divide. If they've got a problem, they will ring us immediately, the Breast Care nurses, vice versa, if we want to check a patient out. We've developed a really strong relationship, which we didn't have in the past. It's improved the quality of life for our patients. We're not getting these big arms that are progressing. A lot of them just wear the sleeve for exercise when they need to do it. But it's absolutely essential to work collaboratively with Breast Care. We always inspect the arm visually. We don't just rely on the LDEX because there are changes in the other arm. We always look at the hand. We've also just started to make sure that we examine breasts as well, because we're getting a lot of breast edemas. I don't know whether anyone's finding an increase in breast edema, but we're getting a lot of breast edemas. And we did have a patient not so many months ago who actually we were seeing for LDEX, and she'd had a breast edema which we hadn't picked up. And that has made us change our protocol completely, that we actually ask every patient if we can inspect their breast. We think that's really important. So it was where we're still falling down is for the patients who have neoadjuvant chemotherapy, because they sometimes slip through the net with their LDEX or getting referred to us. And we've had 3 or 4 in the last few months that have actually not been referred on to us, and then they've been referred with edema. We're working with the breast care nurses with that one. They are a difficult group, and there are an awful lot more of them now with the younger ones, so we've got to tighten up on that, we're getting the referral throughs to them. For our staff, we've got to adhere to the guidelines through baseline measurements. I'm now insisting that if they haven't had a baseline LDEX, we don't start it after surgery because we've got no starting point. So we're not getting a lot of people saying, oh, we'll just do an LDEX on you, but actually it could be completely nonsensical. So we see a lot of patients from the Nuffield because this awkward surgeon now refers all his patients to us, so I must have convinced him. But they don't have a pre-op LDEX at the Nuffield, the private hospital, they don't have it. So they're still referred to us, and we do take measurements just to do something with them, and we see them every 3 months. But that's somewhere where I quite like to get that going as well, because the patients are all keen for it, they want it. They don't want the tape measure, they want this more sensitive. Considering including sentinel node biopsy, we've had a few edemas recently. Patients just had sentinel node biopsy. We do awareness talks for sort of a survivorship group for the breast cancer nurses. And they actually didn't want us to talk about lymphedema at all to the sentinel node biopsy patients because they say it doesn't happen. But we know it does. I know it's few and far between. We don't want to scare them. We've got to get the balance right, but they need to be informed as well. I don't think we'll ever include them in our surveillance program because I think cost-wise it just would not be cost-effective for us to do it. I want to look at the patients who are still getting with established edema. That's what I want to do. Trial, this is what our surgeon wanted, try that patient with, that patient out. Ethically, I find that difficult. If we know that we've got something that's going to work for them, okay, you've got a raised LDEX, you can have a sleeve, you can't. Patients aren't going to go for that. And we were thinking of getting involved with the trial that they did with the parameter and the bioimpedance and looking at the two. But again, our patients were getting a good deal, what they felt was a good deal and good treatment, and not one of them was interested in that because they were left longer and then developed problems. So I think we're just going to keep going. I'd like to extend it to melanoma patients with the skin cancer nurses, and our gynae surgeons are thinking about sentinel node biopsy, so there's another opportunity there possibly as well, because the machine does legs as well as arms. One thing it does do, it isn't like men. If you put them in as a man, you don't get an option of doing an arm, and we do get breast cancer patients, so you have to say they're female, and then it's happy. And when we first saw that, we were trying to put the male in, and it just wouldn't do it. Couldn't understand it, and then it worked out that actually only women get breast cancer. That's machine.